in Oregon, and I serve on the NWA board as the Western Region representative for the local agency steering committee. Today we are privileged to have Kim Mudd as our speaker. She is a research nurse manager at Johns Hopkins in the Division of Pediatric Allergy and Immunology. She holds a Master of Science in Nursing from the University of Maryland School of Nursing, a certificate in health policy from the University of Maryland, a Bachelor of Science in Nursing from Johns Hopkins, and a Bachelor of Science in Biomedicine from Western Michigan University. She has held several leadership and professional roles related to allergy, asthma, and immunology over her career, has over 20 peer-reviewed publications in the area of food allergy and asthma, and has written 2 book chapters on food allergies. Thank you very much for being with us today, Kim.
Thank you. We're going to start this morning, or this afternoon, I guess, and I want to kind of talk about food allergy in general. Some of this will be a review for some of you guys, but I want to make sure that we're all on the same page when we talk about food allergy. So when we talk about food allergy, that whole kind of generic definition of food allergy is food intolerance, which is really a generic term that describes any adverse reaction related to food or food additives. When we talk about food allergy, we really are talking about a very, very specific interaction between food and the immune system. We call this IgE-mediated food allergy. There's a ton of other things that belong underneath this food allergy umbrella, celiac disease, food protein induced endocrinitis, things like that. But what we're talking about today is very specifically this IgE-mediated disease. And what we're talking about is the kids who are at risk for anaphylaxis with ingestion. So anaphylaxis is a severe life-threatening reaction, usually involves multiple body systems, requires immediate treatment. Many things cause anaphylaxis. The #1 cause of anaphylaxis by far is food allergy, and these are the kids we're talking about today. We're talking a little bit about diagnosis because it's going to have some pertinence later. The history and physical are extremely important when we're talking about food allergy, mainly because the prick skin testing and that food-specific IgE measurement, which is done by blood, those are very inaccurate tests. We have a high incidence of false positive with these tests. It's what we have to work with, and they're helpful, but they have to be taken in context of a food allergy history. Part of the other things that we do when we're talking about diagnosing food allergy is doing food elimination diets, where we'll say, okay, we're very suspicious that this food is causing problems. Let's take it out of the diet for a short period of time and see if the symptoms clear up. And the gold standard for food allergy diagnosis by far is an oral food challenge. This IgE measurement I alluded to earlier, this would be skin testing and or blood testing for specific IgE to peanut, milk, egg. You could do the same thing for ragweed, cat, and dog. They are not helpful without a history. There's a very high false positive rate, and what happens frequently is we'll have kids come to see us in allergy clinic where somebody has drawn blood, looked at these positive tests, and told this family, oh my God, your child's allergic to these 10 foods, you have to stop eating these immediately, and these kids come to clinic and they're living on, you know, Nutramigen, rice, and chicken, and come to find out, you know, 9 of those 10 foods, even though the kid has a positive skin test and or a positive blood test to those foods, they indeed can tolerate the food. So again, history is paramount in here. Other interesting thing about this IgE measurement is the IgE, the level of the IgE, the blood test, and or the size of the skin test does not predict severity of any reaction. We have people that have these great big skin tests, and indeed either they can tolerate the food in their diet or they have minor symptoms with exposure to that food. And then I've seen people with tiny little skin tests and low IgEs, and we bring them in to do a food challenge because we think that's indicated, and they have these big anaphylactic events. So the size of the skin test, the level of the IgE does not correlate with the severity of reaction. Again, these numbers are useful. I mean, if we're finding numbers are heading down as opposed to up, that gives us some hope. Maybe somebody's outgrowing something. And again, in context of history, these numbers are actually useful. So when we talk about food allergy, really what we're talking about is an interaction between, as I said, the immune system and the food protein. The part of the immune system that gets things rocking is their mast cells. You have mast cells in your skin, gut, and respiratory tract, and that's what you react with. when you, and I think a lot of people are very familiar with some of these symptoms, for instance, hives, angioedema, which is swelling, eczema. It makes, the skin is the most common system to react when you're having any kind of a food allergic reaction. However, if we're waiting for skin symptoms to occur before we decide somebody is having a food allergic reaction, we're going to miss some stuff. So while it's the most common system, it doesn't require that you have skin involvement to call it a food allergic reaction. This is the kind of symptoms we're thinking you see frequently. This amount of swelling, that picture on the top is probably somebody who ingested something as opposed to having it on their hand or rubbing it in their eyes because it's both sides. If you look at the kid at the bottom, if you can imagine that much swelling on the inside of the airway, very quickly appreciate how this becomes a medical emergency quite quickly. This is hives, raised, red, very, very itchy, and as you can tell, these hives can go total body wide. Another system very frequently involved with a food allergic reaction is the GI system, and this makes sense because you put the food in the gut, and it makes sense that the gut would respond. Vomiting, abdominal pain, diarrhea. There's another thing that kind of lives in this category, oral allergy syndrome, and basically what this is people who are sensitized to pollens. A lot of times, especially when the pollen season's at its peak, will have problems with ingestions of fresh fruits, fresh vegetables. People say, cantaloupe makes my mouth taste furry, or the skin of the apple makes my mouth really, really itch. It's actually an interaction between, your body thinks you're eating a birch tree, basically. So that reaction is very limited to oral pharyngeal area, does not go further than that. But we always have to do a decent history because we need to differentiate between this oral allergy syndrome and then early symptoms of anaphylaxis, okay? Other systems involved in a food allergic reaction include the respiratory system, and we do throw the upper airway, so the red, itchy, watery eyes and nasal congestion and rhinitis goes in here too. The respiratory system involvement in a food allergic reaction becomes an emergency very, very quickly. So we tell anything basically south of the mustache. So tongue and lip swelling and itching, drooling, which would indicate somebody's not able to swallow their own spit, that's a bad sign. Throat tightness, change in voice, that staccato cough. Stridor, which is the sound if you take a balloon and yank on the neck of the balloon and let the air run through it, it makes that little ee noise. That's a very bad sound to come out of a kid. Coughing, wheezing, and cyanosis. Cyanosis is when you're turning blue. You can see this kid has had, this is well after treatment, let me be very clear. You can see how swollen his eyes are, how red and runny they are. He's got a pretty good schneck going there. His his bottom lip is clearly swollen, and his tongue doesn't fit in his mouth anymore. This is a kid having anaphylaxis. And then left untreated, the symptoms of a food allergic reaction can progress to shock. This can take time, or sometimes kids go from 0 to 60 in half a minute. So, and this is scary. Lightheadedness, loss of consciousness, decreased blood pressure, thready pulse, and of course untreated, this can result in death. There are every year multiple food allergy deaths. It's hard to get a number on them because they a lot of times get reported as death from asthma because the kid has underlying asthma. But our guess is it's probably about 280, 300 deaths a year related to food allergy. So severity of food allergic reactions are based on multiple different things. Most commonly, it's the amount of food ingested. So if you've got somebody who is food allergic and they eat a food that they are allergic, and notice I'm saying ingestion, that is by far the highest risk. Will you have reaction if you have the food on your hand and rub it in your eye? Is your eye going to swell? You betcha. If you get kids get those hands in their mouth, are they going to get swollen lips or tongue? Perhaps, okay? But the biggest risk for anaphylaxis certainly is ingestion, and the amount of food that you ingest, the dose, if you will, has a lot most to do with the severity of the reaction. The form of the food, so cooked, raw, or processed, cooked milk, cooked egg, not nearly as allergenic as raw milk or raw egg. Up to 70% of people who are truly milk and egg allergic can actually tolerate baked milk, baked egg. They can't tolerate it in a raw form, but they can tolerate it baked. Then we look at things like peanut. Well, most peanut in the U.S. is roasted, and when you roast peanut, you actually expose epitopes and make it much more allergenic. So how the food is processed or cooked depends contributes significantly to the severity of the reaction. Co-ingestion with other foods. If you've eaten something that you're allergic to with other foods, sometimes what happens is there's a slow absorption of the allergenic food, which may or may not have an impact on the severity of the reaction. Usually we find if kids have eaten some things, for instance, if they had a little bit of peanut on something that's a little bit of exposure, with something else, and the absorption slowed down, the reaction, while still present, won't be as severe as if they ate it all by itself. The other things that influence the severity of allergic reaction, the degree of sensitization at the time of ingestion. If you're allergic to 3 foods and you're smack in the middle of your ragweed season and you're already primed with all the ragweed outside, the likelihood that a little bit of exposure is going to cause a much bigger reaction is very high. And the rate of absorption of the food. Food eaten on an empty stomach gets absorbed very, very fast, and that protein hits the system very quickly. Exercise increases the metabolism, and again, food eaten, and then kids, we see this all the time, they tolerate the food unless they go outside and ride their bike or jump on the trampoline after they eat, and that increase in metabolism gets that protein into the system faster, and they can't tolerate that. And then the presence of coexisting conditions. Asthma, it turns out, is the most negative predictor for a bad outcome. So if you have asthma, kids with asthma are at the highest risk for bad outcome with their food allergic reactions, put it that way. Severity of allergic reactions cannot be predicted by past reactions. That's primarily because of the things we just talked about, the whole dose thing and everything else. Again, the size of the skin test and the level of IgE do not predict the severity of reactions. And again, the most common factor most commonly identified with poor outcomes is the coexistence of asthma. Treatment of food allergy. Strict avoidance. It's very, very difficult to accomplish this, and I don't think I need to tell you guys this. This is the label reading and the checking every label every time, and worrying about cross-contamination and changes in processing and things like that. Major, major impacts on quality of life because of time and cost and you name it. People get very, very isolated socially because it's very difficult to get other people to understand the level at which they need, the information that they need about the food, and you can't have used the same knife, and you can't, all of the things that we all know about. And there's significant nutritional risk. You take milk, egg, and peanut out of a Munchkin's diet, you've got to replace those fats and those calories and that calcium and everything else with something else. So it's a very, very difficult thing to do. And then this waiting for the allergens to be outgrown, which is like, really, this is as sophisticated as we get. It hurts when I lift my arm. Well, then don't lift your arm. I mean, really, we wait for the allergies to be outgrown. Peanut, tree nut, fish, shellfish, seeds usually have a tendency to be lifelong. There's about maybe 20% of kids who are truly peanut allergic or have a peanut allergy reaction early on will outgrow their peanut allergy. The vast majority of them don't. Tree nut, seed, fish, shellfish have a tendency to come on later in life, and we're pretty sure that once an allergy comes and gets seeded later in life, it's not going away. We used to see milk, egg, and peanut, or certainly milk, egg, and soy, maybe wheat allergies outgrow early on. It was unusual to see kids carry those allergies into school age years, and now we're seeing kids in their teens with milk and egg and wheat and soy allergies. So maybe now a little more persistent than it was 20 years ago. And then treating reactions when they occur. So don't eat it. Wait for a reaction to be outgrown, and then treat reactions when they occur. And as we've already discussed, these reactions can be pretty significant. This is the treatment of choice for anaphylaxis. The EpiPen is the one that was in the news so many weeks ago about somebody jacked the price 600% on it because they could, making these unaffordable for many, many families. They're supposed to have 2 EpiPens at school, 2 EpiPens at home, and 2 at daycare. And well, in some cases, that's about $3,000 and out of pocket, and that's outrageous. This AviQ is the device that talks to you and talks you through giving the epinephrine. Also an auto-injector. It got pulled off the market a couple of years ago. We have heard that a company has bought the device and is actually interested in getting it back on the market this spring. Hopefully with the competition, we'll have, it'll bring the prices down on this extremely important med. So risk factors for developing food allergy. Family history is very important. The family, if mom and or dad has atopic disease, food allergy, eczema, asthma, hay fever, the kids have the propensity to inherit that phenotype. And how they choose to express it has a lot to do probably with environmental exposure. So if mom is allergic, the baby's got about I think it's a 60% chance of being allergic somehow. And if mom and dad both come into the baby with atopic disease, then the baby's got an 80% chance of being atopic. Now dad could have hay fever, mom had asthma, and the baby could have eczema and food allergy. So it's not a direct correlation, but it's certainly a tendency. Presence of eczema. So if you look at little guys, somewhere between a quarter and a third of those kids who are under 5 that have whammo bad eczema, a third of those kids have a food allergy trigger that is contributing to their eczema, right? Are there other things that contribute? Absolutely, environment, everything else, but those kids need to be evaluated for food allergy if they have eczema. Same with kids who develop eczema in the first 3 months of life. Something like 90% of those kids have a positive IgE to milk, egg, or peanut. So food allergy has to be evaluated, or any of the little guys with bad eczema have to be evaluated for food allergy. Okay, this is when I talk about severe eczema. This is what we're talking about, and this is going to have importance when we start talking about some studies. So bad eczema is something that requires daily treatment with topical steroids and or let me see here, more than 12 days out of the last 30 days. That is considered severe eczema, and you can see looking at this is a real itchy, ugly rash that's very, very difficult to control. So severe eczema, here we go, the application, topical creams, and a rash that lasts for at least 12 out of the last 30 days. So we know what food allergy is. We know what the symptoms look like. We've talked about how to diagnose this and what the risk factors are. I would tell you the prevalence goes up every time we look at the numbers. So it's somewhere around 10% of kids under age 12 months. So what we don't know is how to prevent it. So a lot of interest in this, a lot of push to get something done. We have to do something about this. So in 2000, the American Academy of Pediatrics came out with a set of guidelines about infants at high risk for developing food allergy. So, you know, these kids that have a strong family history, and the suggestion was that they would benefit from exclusive breastfeeding or introduction of a hypoallergenic formula. So we're talking about a Nutramigen and Elecare, something of that nature. Conclusive studies not ready yet at this point for definitive recommendations. However, the following recommendations seemed reasonable at the time. What came out of that 2000 recommendation was breastfeeding moms should continue breastfeeding for the first 5 years, first year of life or longer, first year of life or longer. Solid food should not be introduced until the diet for high-risk infants until 6 months of age. Dairy products should be delayed until 1 year, eggs until 2 years, peanuts and nuts and tree nuts at 3 years. And I think a lot of pediatricians followed this, and we all did too. What we didn't appreciate was, despite all these recommendations, food allergy kept rising. Every single time we look at the prevalence rates, they went up, and they went up a lot. So what did we do wrong? How did we screw this up? One thing is the broad sweeping recommendations that were made by this recommendation in 2000 were based on pretty low quality evidence. You know, caveats to the data that were collected were ignored. There was a whole collection of data looking at the introduction of hypoallergenic formulas that found out later all those articles had to be pulled because the data had been forged. So bad data and bad interpretation of good data. There was faulty mechanism theories that we had theories, but they were wrong. We gave into when I say we, I mean the medical field in general, gave into pressure to do something because these numbers kept going up so dramatically. And the most important piece of this is that we totally underestimated the possibility of doing harm. And then came the LEAP study. So observations have been made over the, for a while, and somebody finally put it into a study and said, look, if you look at kids in Jewish children who live in Israel, their incidence of peanut allergy is very, very low, less than 1%, 0.17%. And yet, if you look at that same population of kids, so same genetic background, let's say, who live in the UK, they have an incidence of prevalence of peanut allergy about 2%, which is pretty much what we see here in the US. Why? Turns out that in Israel, one of the first foods that is introduced into kids' diets is this bamba, which it looks like a cheese puff, only instead of having the orangey, cheesy stuff on it, it has powdered peanut on it. And that's one of the first foods that kids in Israel get added to their diet. So this study was designed and done in the UK. It was a randomized trial of peanut consumption in infants at risk for developing peanut. So there were 640 kids, little guys, 4 to 11 months old, and they all had severe eczema. Think back to those pictures we saw, those horrible little cheeks, and or a diagnosed egg allergy. All right, so these are not kids that just have a positive skin test or a positive blood test to egg. They have demonstrated that they're truly egg allergic. So high-risk group, bad eczema, and or an egg allergy. The kids were brought in and evaluated and assigned randomly to either eat peanut or not eat peanut. And they started it at 4 months. So these are little kids. The kids were followed out for 5 years, and they were evaluated for the presence of peanut allergy. And guess what? So if you look at this study, let me see if I can get this going. Here we go. If you look at the kids, so this is the kids who were brought in. Let me start from the beginning. So kids were identified with eczema and or egg allergy. They brought them into evaluation and they skin tested the kids to peanut, okay? If the peanut was less than 4 millimeters, which is pretty small, then they were able to be randomized to either eat peanut or not eat peanut. The kids that were assigned to eat peanut were then sent home eating peanut every day, okay? There we go. So this group here, these are the kids that had a negative skin test to peanut, okay? And they were randomized. You guys go home and eat peanut. You guys avoid peanut, and we'll see you in 5 years. And at the end of the 5 years, the kids that were eating peanut, only 1.9% of those kids developed a peanut allergy compared to 13.7% of the kids who had been sent home, don't eat peanut, avoid peanut, okay? Then you look at the skin test positive group. So these are the kids that came into the study and had a positive skin test to peanut, not a big one that was under 4 millimeters, but they were still sensitized to peanut. They actually had an introduction of peanut under observation before they were sent home, but then they were sent home, you guys eat peanut, you guys don't. And the group that was sent home saying, you guys eat peanut, only 10% of them developed a peanut allergy. And the kids were sent home saying, don't eat peanut, avoid it. Overall, 35% of those kids ended up with a peanut allergy at 5 years, okay? If you look at this group together, the kids that were eating peanut, were sent home eating peanut, 3.2% of them developed peanut allergy, and 17% of the avoidance group developed peanut allergy. So what we know then is early introduction to peanut significantly decreases the frequency of development of peanut allergy. Okay. Just wanted to show you what skin tests look like. These are obviously a bigger kid and not a baby, but when you look at the size of a skin test, you measure from one edge to the other and then this way and get an average. These skin tests are probably, I'm going to guess and say 6, maybe 8 millimeters. This is a 3 millimeter, I'm guessing at these. But so these kids that we were talking about earlier that were sent home on peanut, their skin test had to be this size or smaller. Anybody who came in and had this size of a skin test to peanut, they were not part of the study, okay? They didn't get introduced to peanut. So from this group, from this LEAP study came yet another set of guidelines, all right? And this is for kids that we are concerned are going to develop a peanut allergy, okay? So our first group is this high-risk group of infants. These are the kids with severe eczema, remember the pictures, egg allergy, or both, all right? So these are kids that are high risk for developing peanut allergy. The recommendation is to strongly consider evaluation with a peanut-specific IgE. That's a blood test. Now, the LEAP study was all done with skin testing. The difficulty is that most pediatricians cannot skin test in their office. They're not set up for it. So we're doing this based on blood. If the results to peanut are negative, basically, then those kids should have home or supervised introduction to peanut. A lot of these families are not going to be happy being sent home saying, go ahead, eat peanut at home, you're good. So they're going to want to have supervised introduction. The parent's going to ask for it. If the peanut IgE is more than negative, so anything over 0.35, those kids need to be referred to a specialist for skin testing and further evaluation. These kids are at high risk for having a bad reaction to peanut, okay? So if the skin testing is recommended, so these kids right here that we say, okay, you've got a positive IgE blood test to peanut, we need you to see allergy. Allergy skin test them to peanut. If that peanut skin test is teeny weeny, 0 to 2, then again, home or supervised introduction to peanut at 4 to 6 months. Most of those families are going to insist on that being done under observation, but they're already plugged into the system, so there's hope for that. If that peanut skin test comes out to be 3 to 7 millimeters, which is a little bit bigger than what we were looking at in the picture before, at that point, the only way to get peanut into their diet is to do this supervised introduction or graded oral food challenge at about 4 to 6 months. This is going to be done in a specialist's office. This is a very tricky technique to do, okay? And if that peanut skin test on this group of high-risk kids, so bad eczema and or egg allergy, if the skin test comes back and it's over 8 millimeters, which is a pretty good whopping size skin test, then that peanut introduction is not recommended, all right? That's our high-risk group. Next group is this moderate or low-risk group. These are kids who have mild to moderate eczema, all right? So they still have eczema, but nothing like we were seeing before, and no egg allergy in this group. So this is a group that mild to moderate eczema, no egg allergy. The introduction of peanut-containing food should happen about 6 months, and again, this can happen at home or supervised. My guess is some of these families are going to insist on a supervised introduction. And then the last group of kids are the very low-risk infants, and these are kids that don't have any eczema, they don't have any known food allergies, and the suggestion is that the peanut get introduced at home when the other solids are being introduced, and there's no age recommendations. So how much peanut? How much? How much? When? How? How do I do this? So the goal dose is 6 grams of protein per week, usually fed over 3 feedings in a week. So we're not talking about trying to get peanut in the kids every day. We're looking at 3 times a week, which is about 2 grams a feed. And you can use peanut butter. You have to thin it because these are little guys. They're 4 to 11 months, 4 to 6 months, depending on what group they fell into. And clearly, they're not going to be able to handle something this consistency. If you take the peanut butter and you thin it with warm water, you can get it down to something that's more manageable for somebody who can handle with a spoon. This defatted peanut flour is actually very helpful. You can mix this with purees. And again, so the goal dose is about 3 tablespoons a week for the peanut flour and about 1.5 tablespoons a week of the peanut butter. Okay, so what could possibly go wrong? Well, part of the problem is that of the kids were 11% of the kids that were in that LEAP study, so this is what we're all basing this on, were excluded because their skin tests were so big. Remember I said that those kids, if they had real big skin tests, they were not invited to participate in the LEAP study. They didn't get assigned to peanut or restriction. They just got assigned a restriction. But if you look at that group of kids, those kids that did not get assigned to a group in the LEAP study because their skin test to peanut was too big, by 5 years of age, 78% of those kids had true peanut allergy. They failed a peanut challenge, okay? If you extrapolate the data from the one-year-olds, it suggests that up to 80% of the kids with that large skin test were already sensitized when they came into the study. So at 4 months old, these kids they're already peanut allergic, all right? So we know that there's kids out there who are already allergic by age 4 months, okay? What else could possibly go wrong? Of the kids that were randomized in the LEAP study, 2% of them failed the baseline peanut introduction, all right? They had mild symptoms. It wasn't a full anaphylactic reaction, but they were already allergic, and they had a small skin test, okay? So these are the kids that did qualify to be included in the study. They had positive skin test to peanut, but it wasn't huge. It was under 4, and when they did the peanut introduction under observation, 2% of those kids had reactions and were not eligible to continue the study, obviously, but it does have implications for our home introduction. 60% of peanut allergic kids have no history of egg allergy or severe eczema. So these kids are not going to be identified by our high-risk, low-risk group, all right? These kids are going to be low-risk kids because they don't have eczema and they don't have any history of egg allergy. We think about 10% of siblings of peanut allergic kids have peanut allergy. We think about 10% of those sibs. That, again, that data may be very, very biased on our part, but we don't have good data on those kids with mild eczema. So the answer is maybe we should just skin test or blood test everybody. So if we do that, so 22% of the kids in the LEAF study had a positive peanut blood test. Only 2% of them reacted at baseline, right? So we've got, remember we talked about the fact that this testing is very inaccurate. It has a high false positive rate. Well, it has a high false positive rate. So if you start blood testing everybody, you're going to significantly overestimate who's potentially peanut allergic. There was no statistical significant relationship between that peanut IgE, the blood, and failing that baseline challenge, all right? So the blood work, it comes up positive, but we can't equate it back to whether or not the kids are going to pass or fail that peanut introduction. Of the kids with the positive peanut IgE, so these are kids that were blood tested as part of the study, 96% of those kids passed the peanut challenge, all right? So again, this, you know, these results, these studies, these blood work is not very accurate. Okay, then let's do skin testing. Skin testing was a little bit better at predicting, but not great. Of the kids with detectable peanut skin testing, 87% of those kids passed peanut introduction. So the vast majority of kids with a positive skin test passed, they are able to tolerate peanut. It's the size of the peanut skin test helped a little bit, but not much. And remember, in this study, anybody that had a skin test over 4 was excluded, all right? So our blood test, not that great. Our skin test, better, but not great. Why do we care? Well, we care because if you look at a birth cohort, this was done in Ireland, about 5% of the kids had severe eczema and or egg allergy. So those are going to go back to, and these kids would be identified in our population as high risk, okay? In the same cohort, if you look at that same cohort, about 19% of the kids overall had eczema. So those kids would be, so this group, this would be our high risk group, this would be our lower risk group, okay? If you start doing the math and try to figure out, if we assume that this is how everybody's going to be, in the U.S., we would have somewhere between 192,000 to 748,000 infants a year who would need to be screened. And if you looked at those kids, somewhere between 57,000 to 224,000 of those kids would come up with a positive IgE, all right, be it blood work or skin testing. There's only 5,000 board-certified allergists in the United States, and most of them don't see kids, and very, very few of them are able to do a food challenge in their office. So without further evaluation and testing, you've now identified a huge group of kids and said to the parents, okay, we're going to do blood tests, and this blood test positive to peanut. Now what are we going to do with that information? What are we going to do? Because we cannot see all those kids. And the most logical thing would be to say to that parent, I can't guarantee it's not going to react at home, so I guess you should stop, so don't introduce peanut. And without further testing evaluation, we'd have about 50,000 infants falsely diagnosed with peanut allergy every year, all right? So what are we going to do? Well, we've got studies, because we always have studies. We are looking right now for infants that are, actually this has started, and the kids have to be 4 to 11 months old, either siblings of children with peanut allergy, those with moderate to severe eczema, or kids with other food allergies. Anybody interested, this is the contact email for Dr. Keat. And we still have areas of controversy that we're not quite clear on. One of the things is, what age should the peanut be started? I mean, we're guessing at 4 to 6 months. It's a little hard to start earlier than that, but remember way back when we were talking, at 4 months, some of those kids were already not only sensitized, but allergic. So maybe we should have started peanut even earlier with those kids. How? I'm not sure, but, you know, should we be starting this at 2 months? Or maybe that's way too soon and their gut's not mature enough to handle solids, and we really would be doing more harm than good. What about other foods? If this works for peanuts, should we be doing this for cashew and walnut and sesame and milk and egg and all the other foods that kids are allergic to? We don't have any data on that. So what we know is that the introduction of peanut in the first year of life protects against peanut allergy. We don't know what the optimal time is for that peanut introduction, or whether or how to screen for high-risk infants for peanut allergy prior to the introduction. Is very, very difficult. The same concept may hold for other allergens. Many infants are allergic to concentrated eggs, or introduction of uncooked egg before other forms of egg may be not advisable. I mean, we need more data. And we don't have good information on other foods. So we have work to do. Job security, we have job security. These are some great, great resources. So this is the NIAID expert report on food allergy in general. There's two different versions. There's a whole PDF of the entire report, and then there's a real good, this user-friendly version of it is actually searchable if you want to just sort of get some more background on food allergy. And this NIAID Food Allergy Guideline webpage actually talks about introduction of peanut, and it's broken down by clinicians, parents, and then it has the actual web page, so this is pretty helpful. And then if anybody needs it, this is an online training for administering an EpiPen, which, you know, that's public health stuff. So I think, yeah, okay, that's sort of where we had planned on ending today for questions.
Yes, so this is Natalie Malloy from National WIC Association. If all of you look down on the right-hand side of the webinar, you'll see a tab that says questions. If you type in the box and click send, it'll show your question, and I will read them out so Kim can answer them. And we already have a question. Are you ready, Kim?
Yeah.
Okay. A couple of years ago, they had a conversation with an allergist who suggested that it's a problem to introduce foods through a non-enteral route, i.e. skin testing, and that skin testing may actually lead to allergies. What are your comments?
Absolutely not. We've been skin testing kids for decades and have no concerns that that small amount of exposure is actually sensitizing children.
Okay. Someone asked if the slides are available from this webinar, and yes, I believe, Kim, you said that was all right with you. We'll be sharing those.
It's fine.
Great, thank you.
While we're waiting, Natalie and I had discussed this. I wanted to, because I'm a research nurse, and when you invite a research nurse to talk, you get research. And about this, Natalie's going to interrupt me as questions come in with so that we don't, I want to make sure that you get your questions answered. But we're treating food allergy now. We've got kids who, you know, are well beyond the early introduction, and by the time we see them, they are food allergic. And be that because the food didn't get introduced the right way or soon enough or whatever, it doesn't matter. It's water under the bridge. Now we have food allergic kids. What are we going to do about it? And we're not still passively waiting for food allergy to resolve. We're looking at trying to attack food allergy with anti-Ig antibodies called Zolair, Chinese herbal formula, immunotherapy. This is a big, right now, this is very, very big. You hear a lot about this in the news, using intact allergens or modified allergens. This ingestion of extensively heated milk and egg, as I alluded to earlier, 70% of kids who are truly milk and or egg allergic can tolerate baked milk, baked egg in their diet, which is a gigantic step in the right direction for quality of life, because really what those kids want, they don't want to eat an omelet, they want a cupcake. And what we're finding is that if you can actually get this baked milk or baked egg into the diet, even in small amounts, it seems to help the immune system sort of downregulate to the regular milk and so the untreated milk, unheated milk, and the rawer kinds of eggs such as omelets and scrambled eggs and stuff. So that's turning out to be a huge step in the right direction for little guys and big guys too. And this transdermal absorption, so the patch, that's a big, another something you're hearing a whole lot about it in the news. The challenges.
Sorry to interrupt you. We have a couple of questions. So here's one that says, are there any dietary recommendations for breastfeeding mothers about whether or not to eat peanuts or other allergen foods to sensitize their babies via breast milk or before the age of 4 months?
Good question, and it's a very good question, and we don't have any good data. We all know that whatever mom has in her diet will be expressed in breast milk, intact proteins. We know that. We've seen that before. And is that a good way to start this desensitization process or this introduction, let's say, for little guys? Maybe, or maybe the dose isn't high enough, and that actually is more sensitizing than inducing tolerance. We don't know, but it's a really good question, and one hopefully that we'll have some more data to answer in the future.
Great, thank you. We have another question that asks if you see fewer allergies in rural children than in urban children.
Oh, absolutely. There's something called a hygiene hypothesis, which basically says the reason that we have so many allergic kids is that you've got this very, very functional immune system, and it has nothing to do. I mean, we have clean water, we have, vaccines, so all the things that the immune system is primed to take care of are already being taken care of. And really what an allergy is just an overactive immune system. When you look at kids from rural countries or countries where the barn and the house, there's not a lot of distinction between the two, so the kids have a lot of exposure to large mammals. They have a tendency to make endotoxin. The big, cows and horses and stuff make endotoxin. Kids get exposed to that, and their immune system deals with it. But the immune system's busy. It's busy taking care of a cow endotoxin. It doesn't have time to worry about milk and egg and peanut. In countries where the kids get exposed to a lot more dirt, if you will, much lower prevalence than all the atopic disease, food allergy, eczema, asthma, hay fever, the whole 10 yards. We have a tendency to see that in rural populations, just again because it has a tendency to be more farming and more exposure to endotoxins and things like that, which again keeps the immune system busy.
Great. Here's another question. Do you use skin testing as a starting point before doing an elimination diet to narrow the number of things they eliminate and get faster results?
We do use combinations of skin testing and blood work, plus, again, in context of history to see, because you've got a negative skin test or a negative blood test, it's very unlikely that that food's causing a problem. The challenge is that you have a kid that comes in, bad eczema, they're making a ton of IgE. You look at their skin test and their blood work, and everything comes back positive. And it's like, oh, great, now what? So then we're looking at the things that are most prevalent in the kid's diet to see if we can eliminate one of those big food groups who can get their skin cleared up. And these would be kids who are well beyond our, we're trying to prevent allergy. These are kids that are coming to us with allergy. Now we're trying to figure out what the triggers are to back up a little bit, give the kid time to get their skin settled down before we try to start reintroducing foods. But yes, we do use skin testing as well as blood work in making that determination.
Thank you. The next question is, how are milk allergies determined in an infant less than 6 months who shows allergy to milk-based formula?
So skin testing and blood work, you can get, I've skin tested newborns, so you can get a positive skin test or a negative skin test, which would be even better. And same thing with blood. You look at the IgE specific to milk in the blood.
Great. So is there any sign of a connection between soy infant formula and soy or other allergies later in life?
I'm not sure I understand the question. Soy infant formula is soy protein, and kids that are allergic to soy infant formula would be allergic to other forms of soy until such point they either outgrew their soy allergy or retreated their soy allergy with immunotherapy. Hopefully it answers the question.
Thank you. If a prenatal who's having nuts or any other allergens, how does this sensitize the infant?
Tell me again.
So did you want me to read it again?
I'm sorry.
It's okay. So if they're having nuts and or other allergens. So if they're having, I guess, a reaction, how does this sensitize the infant? Maybe could the person who asked this question
I need a little more information. Okay. I'm not understanding the question. I want to make sure I can answer it for you.
Okay.
Sorry.
No, it's fine. Whoever said that, if you remember, please type it in again. Okay. So here's the next question. Sorry, to everyone else, I just want to remind you that if there's specific personal questions, that please avoid doing so and refer to your physician.
I don't want to be giving advice out to anybody, specific questions to specific kids. Only in that I've never laid hands on them, and that would be so inappropriate. But go ahead. I'm sorry, Natalie. Keep interrupting you.
No, it's fine. I'm just going through them. And so someone said, I have heard that the first 7 to 10 days of elimination is culprit food may cause worsening symptoms before getting better. Have you found this to be true at all?
Yeah. Usually what we've seen when we use elimination diets, it's usually because somebody presents with an unclear case. So if somebody comes in and says, boy, I fed him, he got a Ritz Bits cracker with a little bit of peanut butter in it and his whole face blew up. Well, there's no need for an elimination diet. That kid had an allergic reaction to peanut and you're done. So sometimes it's not so clear, and it's usually when kids present with that bad skin, and we get the skin testing and or the blood work, and mostly the blood work because sometimes there's not enough intact skin to do skin testing, and you have all these foods that you're suspicious of. You go back and talk to mom, well, what has he been eating? What's the biggest protein in his diet? It's going to be milk or soy or occasionally wheat or egg. What we'll do is say, okay, let's do this. So if mom's breastfeeding, take that out of your diet. If the baby's only eating, say, formula and purees and solids, then we'll pull that out of the diet and see if we can get the skin cleared up. So that's usually what we use those elimination diets for, is a case where it's really not clear what is causing the problem, and it's almost always, the problem's almost always the problem's almost always skin. So that's where we would use those elimination diets. But usually what happens when you get the culprit food out of the diet, skin starts clearing up pretty darn quickly, and then we know that we're on the right track.
Great. So here's another question. How do you suggest we refer mothers who have been denied allergy tests by their doctor due to being too young?
That's, there is no too young. There absolutely is no too young. So I don't know if the referral was refused by an allergist or the pediatrician refused to send the kid, but like I said, I have skin tested, newborns. So pediatric allergists will see anybody from days old to all the way up to 22. So it's either they weren't referred to the right allergist, and or the pediatrician needs to be re-educated.
Okay, and someone else asked, can you describe how skin testing actually happens, and is it painful for infants or kids?
So what we do is you take the extracts are a highly purified version of the protein in a liquid form, and somehow you need to introduce that liquid into the upper dermis of the skin. Usually what we do is take we call them prick devices. It looks like something that maybe has like a small crown at the end, and really what it is like similar to like running your fingernail, like flicking your fingernail across somebody's skin. That's really how little effort it takes to get that protein in the upper dermis of the skin. What happens is that the mast cells in the skin and the surrounding area either recognize that protein and they has a small inflammatory response, which is where you get that wheal and flare that we were looking at earlier, or the mast cells in the skin see that protein and go, yeah, whatever, it's not something we care about, and there's no reaction at the skin. The worst part about skin testing is that it's itchy, but it's very manageable. You can read the skin test in 10-15 minutes, get your result, and clean everybody up, put some hydrocortisone on, and everybody gets on their merry way. So kids tolerate this extremely well. And again, we're not talking about the kind of skin testing where like when you get a TB test, where you take a small needle and put a bleb under the skin. That's called intradermal skin testing, and you never do that with food allergy, because the introduction of that much protein under the skin can actually cause a systemic reaction, plus the fact that we already know that our prick skin tests positive or have a high false positive rate. You start doing intradermal testing, and the false positive rate goes skyrocketing into the 90% range, and you're getting no good data at all.
Okay, the next question asks, it is recommended for exposure to peanuts before 1, but not tree nuts. Is that correct?
Correct. At this point, we have no data on tree nuts.
Okay. Is there a recommendation for how often children should be tested for allergies to find out if they are still if the allergies are still present, or if they've outgrown them?
Usually, for the little guys, that becomes very dependent on the practice. Usually, we'll test the kids about once a year when they're little, just because there's a lot happening at that point. Once the kids get through school age into adolescence, we'll usually stretch it out to every couple of years, just because somebody that's holding on to a wheat or a milk or an egg allergy at 15 is likely going to take that into adulthood. So unless there's some indication that the food allergy is heading in the right direction, we won't test every year once the kids are, say, adolescents. But that becomes very, very, what allergists will decide what makes the most sense and how they want to practice. So it's going to vary practice to practice, is my point.
Okay, the next question asks, if a child is allergic to egg, is it okay for them to receive a flu shot?
Yes, absolutely. And the most recent recommendations don't even require that they don't have to be skin tested. They don't have to receive that flu shot in the allergist's office. They can get it in the pediatrician's office.
Okay, the next question is, besides the LEAP study, has there been any other demographic groups with meaningful data?
No, this is the first. That was the first one, and many, many coming, but that was the first one.
Okay. The next question is, any comments on the use of hypoallergenic formulas such as Nutramigen or Alimentum? Sorry if I got those wrong.
Yeah,
are they recommended for infants with suspect cow milk allergies, or should soy be trialed first?
Okay, good question. I should listen to the whole thing if I make a session. So yeah, so somebody who comes in, so baby comes in on a milk-based formula, is clearly not tolerating it for IgE kind of things, bad skin, more than just barfy kid, okay? And what we are very clear on is if you take that milk allergic kid and you introduce them to a soy formula, you're just going to tolerize them to soy. So if you've got somebody that has clearly has a milk allergy, right? The smart thing to go to is a Nutramigen or Alimentum, which is the hydrolysate formulas, so that the kid can grow and will at some point, hopefully early on, be able to get that milk back into their diet. But at that stage, once they're already sensitized and not tolerating a milk-based formula, the next smartest choice is an Alimentum Nutramigen kind of a formula. Not soy. And
there's another question related to that, if there are any consequences of using those formulas in the long term for infants.
So those hydrolysated formulas are expensive. They're nutritionally intact. So, and once upon a time, we wondered whether or not we should take kids who were at high risk. So you've got an allergic SIB. Say you've got, baby number 1's allergic. Here comes baby number 2. Should we put that baby on a hypoallergenic formula from the get-go to try to prevent allergies? Well, back to not having enough data to make those kinds of decisions, it would lead us to believe, looking at the LEAP study, that that's probably not a good idea, but that study has not been done. Having said that, once you've got a kid who needs a hypoallergenic formula because they're not tolerating a milk and or soy formula, then going to a Nutramigen or an Alimentum is appropriate, nutritionally intact. Kids grow well on these. And then, at some point in the future, we go back and revisit the whole milk allergy issue to see if we either got somebody who outgrew early, somebody who can tolerate baked milk, or somebody that's going to need immunotherapy to tolerate milk in their diet.
Okay, a couple more questions. If the mother is breastfeeding and the baby is sensitive to a specific food, I might have already asked this about the time frame of when to reintroduce the food. Have I already gone through that one?
Well, you've got, so, you know, we determined that, I mean, it always turns out to me milk and soy or wheat in mom's diet, which is really frustrating because those are hard foods to get out of the diet. So let's say we've got a baby, bad skin, mom's been breastfeeding, baby gets evaluated, we're pretty suspicious that it's milk causing the really bad skin. So we say to mom, take all the milk out of your diet and see if baby tolerates breast milk with no milk, cow's milk in it. And baby tolerates. Wonderful. Now mom doesn't get to put coffee or milk in her coffee, and she's, you know, you worry about mom's nutritional risks because you've taken, again, a big protein out of her diet. And then the question becomes, well, when do we say, okay, let's put that food back into mom's diet and get it back into baby's diet? When do we do that? That becomes a call of the allergist. Only in that, you know, there's a whole bunch of how significant were the symptoms, was there, you know, more than just skin symptoms, were we worried about anaphylaxis? In general, we'd be happy is after we've got the skin figured out, we'd be very happy to try to reintroduce that food back into baby's diet through mom's breast milk to see how the baby does. Having said that, that would be the call of the allergist who actually has laid hands on the baby and knows how significant the reactions were and what the risks are. So hard to answer that one, but yes, that's doable.
Okay, and does anyone else have any more questions? If your question was, oh, just as I said that. Okay, I just got a question that says, if an infant has been diagnosed with cow's milk or soy protein allergy, should they avoid Gerber rice cereal as it contains soy lecithin?
So the soy lecithin is actually so processed and so removed from the soy that it doesn't have any soy protein in it. It's a really good question. So we do not restrict soy lecithin from kids who are soy allergic.
Great. So does anyone else, oh, just as I say that every time. Okay, the next question is, if physicians routinely prescribe soy infant formula for any kind of cow milk formula intolerance, is this advisable?
Well, so it sort of depends on what the reaction was to the cow's milk. Barfy kid who, you know, skin's fine, everything else is fine, just a barfy kid, switching from a milk-based formula to a soy-based formula, it might be fine. A kid who comes in with lousy skin and maybe some, you know, indication of we're looking at something more than just a barfy kid, would I go to soy? Probably not. I'd probably go to a hydrolysate from there. You know, worst case, not worst case scenario, but you know, the concern is that you go from cows-based formula and you end up with a, you know, kid that's not happy and bad skin and a, you know, bad gut. You move them to the soy and it takes them a couple of days, but then you end up in the same place and now you're doing another change of formula in a young infant with a you know, with a young mom or mom that's postpartum, and that's a lot. That just becomes an awful lot to ask of a family and a baby and a mom, but it happens a lot. It does happen a lot. So I think it depends on what when you say not tolerating cow's milk formula, what that non-tolerating looks like.
Okay, well, we do have remaining questions, but we are running out of time. However, Kim has agreed to answer additional questions, so I will, once again, my name is Natalie Malloy, and I will be sending out a follow-up email with the recording and the email of the presentation from this webinar, along with the certificate and a way for you to get in contact with Kim to ask additional questions. If that's it, Kim, thank you so much.
Thank you for having me. I appreciate it.
Okay.